Welcome to a lecture on bleeding and clotting diseases. These are very, very common, and it's especially kind of critical care. A lot of diseases are going to affect your clotting process. It's pretty amazing that it works correctly most of the time, because in your blood you have all these chemicals that are ready, if they're activated, to make a clot, to turn your liquid blood into jelly. And so it's just because it keeps moving and you have anti-clotting factors. It's the only reason that doesn't happen all the time. And you have this balance between needing to make clots to seal any vessels off and not making too many clots, because clots, they travel as emboli and they can get caught places, and they block off capillary beds. And so you got to have this nice little balance. But it's also pretty amazing that your blood vessels are self-healing. You know, if your gas line in your car or plumbing in your house gets a leak, it just leaks, right? You go and seal it up and do the repair. So pretty cool. So let's take a look. All right. So hemostasis means blood is being static or not moving. So this is what you need if you have some kind of injury. And you can imagine if the vessel, a slow leak, you're like, oh, it's a slow leak. But you've got your propane tank with a slow leak. Well, just wait overnight and all the propanes come out. So any kind of leak in this system, it's under pressure too, right? Your blood pressure has got to be stopped right away. And then you'll see, after you plug it up, then you've got to get rid of the plug. You have to repair it. So it's a whole thing that needs to be done here. So it's a complex chemistry. You're going to see all kinds of factors and chemicals involved. But some of those chemicals come from the blood vessels. That endothelial lining secretes antithrombin, nitrous oxide, and things that are going to actually prevent clotting in normal situations. And then when the vessel is ripped open and you expose the connective tissue, then you want clotting to happen. But normally you want the platelets to move on by, don't stop here. Then the platelets are remember the little fragments of cells filled with all these chemicals, these clotting factors. And then the plasma itself is filled with all these clotting factors. A lot of them are in a pro form. So they don't work until they're activated. When other chemicals will activate it, you have this complicated cascade of chemical reactions. So the plasma is filled with fibrinogen and prothrombin and all these chemicals that, under the right circumstances, can be activated. So when you first get a blood vessel that's damaged, what's going to happen right away, what you want is the blood vessel to close off the spasm. And so you're going to see when you rip open a vessel or crushed, whatever happens, the pain receptors there, nociceptors, and you're going to be releasing chemicals, and platelets release serotonin. All these chemicals cause the smaller vessels can even close off. A bigger vessel can close more, so it slows the blood flow to the bleeding area. But the smallest ones, the arterioles, can close off completely, thus giving you time to fix the leak before it opens up again. Then what happens, so you want to do that right away, kind of slow the blood to slow the bleeding. Then platelets are going to go make a plug. They're going to plug it up, and it turns out it's even a positive feedback mechanism. So that when platelets stick, they give off chemicals that attract more platelets. When you have more platelets, there's more chemicals that attract more platelets. So it's a life or death situation where you just make this plug as quickly as you can. And then blood coagulation. That's where you take a liquid blood and turn it into a jelly-like thick blood. And floating around, and remember, blood is a connective tissue. The fibers are going to be, it's going to be this fibrin that's going to come out and make this net. It's going to go over this platelet plug and secure it. And so we'll talk about blood coagulation. So normally smooth, beautiful endothelium. The platelets just go on by, no problem if it's nice and healthy. There's also a tendency for the platelets to stay in the middle so they don't bump against the walls that often, which is also good. Because a platelet hits the wall, it could be activated and you could have these clots forming. So we're talking about avoiding that. So first of all, when you have an injury, the vessel is gonna spasm or close off. And that's gonna help prevent a lot of blood loss, right? And don't worry about it. There's other collateral circulation so that the blood can find its way. And then platelets, they physically constrict it. They also have chemicals. I said serotonin that's going to help that. It's physically obstruct it. They're going to plug it up. Yeah, so you can see this dangerous opening here has been plugged up by platelets. And then we'll see you're going to have fibrin. They're going to be these fibers. It's like a net, a sticky net that's going to really strengthen that. So the important thing, I'm going to start showing you the whole coagulation reaction. You don't have to learn it all or review it all, because of course you all learned it. Fibrinogen is liquid, is dissolved in the blood plasma. And then when you have this thrombin, it's going to convert it to fibrin, a monomer, and then a whole bunch of them come together, make a polymer. It's going to make this long sticky net. Yeah, you can see it here. And it's going to, more platelets will stick to it, red blood cells will stick to it to make this clot. So the most important when we get to all the chemicals is that fibrinogen, there's a liquid, turns into fibrin. And the fibrins will stick together to make this long chain, and that will it'll be not in the fluid, it will be an actual fiber come out of it. Yeah, and you're always going to see these, we're talking about inhibitors, it's so important. At the end, you need to, being a positive feedback, at the end, you need to stop this somehow, right? And so you think about, body thinks about inhibition as soon as this whole thing starts, really. So we're going to look at all these factors. There's like more than a dozen chemicals. I'll have Roman numerals, number 7, number 10. And I'm just going to tell you the ones you need to know here. So these enzymes are going to convert one factor to another. It's going to come down like this. And some of these products here will even go back and enhance earlier ones. So this, like I say, this coagulation, this cascade is sped up the more the clot grows. So thrombin, it's going to be a real key thing you need to know. Thrombin used to be prothrombin. That's your liver makes all these, and it's floating in the blood. And then it's converted into thrombin. And that's going to make the fibrinogen turn into fibrin, and it does some other things too. Yeah, and we'll also see factor 10. 10 you're going to know. It's right in the middle. And what also you need is calcium. You see calcium is needed. You see calcium and vitamin K when you look at clotting. You have problems with those, you're not going to clot properly. All right, so when we get to this, the next one, I'm going to show you the whole clotting cascade, a huge flow chart of how this all works. But pretty much we're going to see this factor 10 is at the middle of it. And the factor 10, you're going to have either 2 ways to get to it, either extrinsic or intrinsic. And then from there, it's the same, everything's the same. But there's 2 ways to get to that, activating that factor 10. And extrinsic is outside of the blood. And so you have a damaged blood vessel. It's going to reveal the collagen beneath the blood vessel, and it's going to have other factors. This thromboplastin is in the tissues. It's going to work as a signal to make the platelets are going to stick like crazy to it. And they don't stick to the endothelial lining, but they'll stick to this damaged vessel. Intrinsic can happen just within the blood. You don't need a damaged vessel. And if you put blood even in a test tube or something, it'll begin clotting. It has this factor within it that's going to begin the clotting, and it'll reach till it activates factor 10, and then everything goes the same. So intrinsic doesn't need that external chemical in the damaged tissue at all. It's 2 ways to get to the factor 10, and then it's all the same. There it is. Fun indeed. Look at that. Woo! There's that factor 10. As I say, there's going to be a couple ways to get to it. To activate it, you can see there. But once you get a factor 10 activated, that's a little A right there. You need calcium. See that? Then you're going to convert prothrombin to thrombin. And the prothrombin is just there. right? And it's safely in your blood plasma. But once that activated factor 10 comes in and there's calcium, it can make it into thrombin. And that's powerful. It can do some stuff. And what it does mostly is turn that fibrinogen, which is a big protein made in your liver, cruising around your blood all the time, but it's always ready. As soon as it has some thrombin, it's going to change into fibrin. And then it's going to combine with others to make this long chain, this sticky net. And there's other chemicals that help stabilize it. It's going to give you a stable clot. Instead of just a bunch of platelets or red blood cells stuck to it, you've got this net that's going to hold it too. So it's called a cascade because it has one factor is going to influence another like that. And here's a simpler version. I put X's over things that are less important. You can see either intrinsic, just within the blood itself, or from damaged blood vessels, are going to get you where you're going to activate this factor 10. And then that's going to activate, like I say, prothrombin to thrombin. Thrombin's going to make fibrinogen to fibrin. Fibrin is going to give you your clot. All right, so you guys feel free, learn it all. Pharmacy school, they learn all these individual factors because drugs work at all these different levels and diseases work at all these levels. You can have a genetic, imagine a genetic disease that your factor 11 is not made right. Well, you're going to have clotting problems, you know? So all these moving pieces have to work correctly. And so there's lots of reasons, ways to get coagulopathies, and there's ways of drugs to zero in on all these different levels to influence clotting. So that thrombin, pretty important, right? Well, a thrombus is a clot, so it has the name thrombin, right? So it's obviously going to make a clot, right? And it activates a bunch. And an interesting thing also is that it's involved with inflammation. And the whole chapter on inflammation. So coagulation and inflammation are going to work together. If you have a damage, you know you have inflammation. So you have a damaged vessel, you want a coagulation to happen, you want inflammation to happen, to start repairing it all. So thrombin, there's a lot of cross-talk between these two processes, the coagulation and inflammation. And thrombin even is going to work as it's going to begin the starting of inhibiting coagulation, you know, because it's a positive feedback kind of thing. So yeah, thrombin has many functions. And so you need to break down this clot. And so here fibrolytic lysis is breaking apart. So the clot needs to be gotten rid of at the end, right? This, I found this picture, it's a huge clot. It's found in a lung. You see how it like went down the different arteries there? Now that thing's not gonna break down on its own. So sometimes surgery is required to go in and get a clot out of the brain or the lung or something like that. But if it's a small clot, your body will send out chemicals that will break down the clot. That's the final part. You want to repair the vessel and get rid of that clot. But real big clots, your body will tend to like kind of encapsulate them or make a granuloma and just, it can't really get rid of it. And if it's in a bad place, they probably think about going in and getting it. Yeah. And if you have a pulmonary embolism, a cerebral embolism, a myocardial infarct happening from a coronary embolism, if they get you to the hospital quick enough, they get you these clot busting drugs. Powerful, and they will go in and they will dissolve these clots. And talking to Lindsay about cardiologists she's working with, and they really, clots are these are heart people, cardiologists, are their biggest enemy. And sometimes they'll go on the edge of really preventing clots, you know, even though it's a risk of bleeding by doing clot busting drugs. But yeah, clots are the enemy to a cardiologist. And so they can give clot busting drugs. I've heard of streptokinase, and there's others that will, if you have any kind of stroke, something like that, that's the main thing, is they give you these drugs if they can break up the clot, and then it restores the blood flow, and they're good. All right, well, normally your endothelium of your vessels give off these chemicals, prostacyclin, antithrombin, nitrous oxide, things. So that's what the deal is. Your normal healthy blood cells, lining of your blood vessels, healthy blood vessels, are giving off chemicals that prevent clotting. You only want it to happen if there's a breach. And so the smooth endothelial lining, so no plaques, smooth, giving off these chemicals, keeps the blood flowing, keeps it flowing, and prevents clots from forming. And I also mentioned the platelets tend to stay in the middle, so they don't hit against the walls. That also helps. But you see where blood vessels bifurcate, they're going to hit, or if there's turbulence, then they're going to cause the platelets to hit the walls. It's always dangerous because they could burst and like start and make a clot. So, and just the picture of the river, just this flowing keeps the clotting chemicals from building up in any one place. So of course the huge danger is when blood pools, behind your legs in a long plane flight or something like that. So if blood is not moving, or blood is real turbulent, that's when clotting can happen. But if it's moving smoothly, then it's only going to clot when it's needed. All right, so major serious issues here. Let's get to them. I'll just give you the main ones here, things you're going to interact with, things that kill people a lot. Well, one is trauma. Common cause of hemorrhage. All of you have scraped your knee, have cut yourself, right? And then you have a hemorrhage. If it's small enough, we could do finger pricks, it's going to clot, no problem. You don't have to do anything. If you, I think it's a hockey player looking at a femoral artery severing, you're going to die quickly unless you get some pressure on that, a tourniquet, and get that fixed, right? That's never going to, no amount of clotting we're talking about is going to help with a big artery, right? You got an aortic aneurysm, it's going to burst, the blood's going to come out, tremendous volume of blood, and it needs to be fixed immediately or you're going to lose blood pressure and bleed out real quickly, right? Yeah, and you'll have bleeding when your platelet count drops. Remember, it's supposed to be 100, 400,000, 100,000. When it gets real low, you can be okay even in 20, 30. You can be okay maybe if you definitely don't want to play any football or anything. But when it gets low, you can have these bleedings occur. You'll see this petechiae, the bleeding under your skin. Or so your platelets are low, or you have defective platelets. We're going to see you can be autoimmune. You can attack your own platelets, but anything that's going to hurt the platelets is going to cause the bleeding issues. And you guys know this term, thrombocytopenia. That means not enough thrombocytes or platelets. And it could be caused because you got a bone marrow problem, aplastic anemia, cancer, it's destroying the bone marrow. And if you did a biopsy of the bone marrow, you wouldn't see many megakaryocytes. Those make the platelets, right? Or it could be, maybe you're making enough. Actually, maybe there's a normal amount. Maybe even there's a lot of megakaryocytes. But on the other hand, you have something that's destroying platelets at a greater rate than they're being made. So you got a big spleen, and it's just, the platelets are getting stuck in there, and it's just taking them out. Or you like that autoimmune disease, you're attacking your own platelets. Or you got a whole bunch of little bleeds, and the platelets are just being used up faster than they're made. So all these things can lead to thrombocytopenia. It's a finding that means you don't have enough thrombocytes, platelets, and you're going to show petechiae, you're going to show bleeds, you're going to have bleeds. And what they can do, of course, many factors go into this, but they can give you a transfusion, give you platelets. And that's not a long-term fix, right? You want to fix the issue, but they can give you platelets so that you don't bleed out right there. Hereditary coagulation problems like hemophilia, it's passed on. The Queen of England passed it on, the royal family. Hereditary is rare to have a hereditary coagulation problem compared to acquired. This is, you get from, like I say, some diseases like that autoimmune disease or some drugs that just hurt your clotting mechanism. All right, a famous pathophysiologist, some people call him the father of pathophysiology, Virchow, came up with this triad here. And for clotting, thrombosis, so the three big pillars of this that cause the unwanted clotting here is going to be damage to the endothelial lining of the blood vessels. Oh yeah. A hypercoagulable state. You've got something, some condition where you coagulate too rapidly. or you got too many platelets, maybe something like that. Another thing is the blood flow itself. Stasis is huge. If blood is pooled, it's going to clot. And then even turbulent as well. So these things I'll go into when you look at a abnormal clot formation. These are the 3 factors you look at. We'll talk more about it. Yeah, and you can look at some of the conditions that lead to this. And here's these 3 categories. Damage to the lining of the blood vessels. So yeah, bacteria, toxins, cigarette smoke, not the smoke, but the chemicals from it are going to damage your blood vessels. Atherosclerosis. So if your vessels are all caked in plaques, the blood vessel is much more likely to clot. Blood vessels actually be damaged as they go across, and the platelets will also be damaged and release their contents. Vasculitis, remember, was an inflammatory issue with the veins. Yeah. Altered blood flow, of course, where the arteries, where they branch. That's a spot right there that's going to, the platelets are going to hit the walls at that point. Definitely, when you narrow the blood vessel, it's going to cause more turbulence in there, so atherosclerosis. An aneurysm, when you have, ballooning out of the blood vessel, you almost always have clots in those, because you imagine the blood is going to stagnate in here and a clot will form. And then the danger is this clot dislodges itself and then it travels and gets stuck somewhere. Yep, and of course stasis. When you're in the hospital, they make sure if you're laying there for a long period of time that you're wearing certain stockings, or they get you up to walk around soon after, because they want to not get blood clots. Now, it can cause hypercoagulability. Estrogen, so birth control pills, combined with smoking too, really bad for clots. Yeah, and you'll see after surgeries and trauma, there's often increasing coagulopathies. Could be something inherited, cancer, obesity. Yeah, cause a state where you're just like a trigger finger. You're too ready to coagulate. Put that together with altered blood flow and then damage to the lining of the blood vessels, you're going to have clotting. And again, just so you guys know this, that clots especially form in the pelvis and lower limbs, and then when they break off, they turn into an embolus. And that's going to travel up your blood into your right side of your heart to your lungs. And the major issue is pulmonary embolism, where that clot gets stuck in the arteries in your lungs, and then big killer. All right, DIC, and then the last slide will be on this too. Disseminated intravascular coagulation. Now, this is, it means intravascular, means in the blood itself. And it's a really serious disease. You see it in, if you're going to work in the critical care unit, something like that, you see it with people who are really sick. DIC is, you do not want to hear that, because what it does is it causes a whole bunch of small clots in little vessels, and that causes little infarcts where the tissue is dying, in places in your body. At the same time, in other tissues, other vessels, you bleed out. There's too much bleeding. And so it's difficult to solve, because what do? You give an anticoagulant, and then the bleeding problem is going to worsen, right? You do something to help coagulation, and then you're going to have more of those little clots. So DIC forms often in critically ill patients, and then it's a real serious life-threatening issue. Okay, so you have a patient, let's talk about symptoms, signs, tests you want to do. If they tend to bleed, you can call them hemorrhagic diathesis. And diathesis, in case you don't know, means a tendency to suffer from a particular medical condition. So this means they suffer from bleeding, hemorrhagic, right? So you want to find out, even your dentists, besides just health doctors and nurses, want to know about this, because if there's any chance that you're a bleeder, it's good to know ahead of time, isn't it? You can be ready for that. When you hear, like, I have a coagulopathy, no, I don't, but if you have one, it means you have a disease of coagulation, right? Pathology, coag. And so it's a general term for a lot of things that could be wrong. There's a beautiful picture down here showing the fibers, and they've captured red blood cells. Yeah. All right, so platelet issues, of course, we've been talking about this, with clotting, that's the main issue. What's going on with your thrombocytes or platelets? And if you don't have enough platelets, you have thrombocytopenia. The petechiae, the little red dots, will form in the skin. They come together as purpurae, the purple ones, or big bruises. And then some other things that will happen, nosebleeds, epistaxis, and then hematuria, means blood in the urine, and hematochezia, fecal blood. And then menstrual bleeding is normal, of course, but too much of it is menorrhagia. We have too much bleeding. And you know these things cause iron deficiency problems, right? But here we're talking about using up, not having enough platelets is going to cause these things, isn't it? Yeah. Especially, you know, after childbirth, you want to really be aware of these things because there's a lot of blood involved as the placenta comes out. And so if you're not clotting, it can be life-threatening. Well, if you have a clotting issue, usually they come in. Here's these purpura, I mean, because they're kind of purple, and the petechiae, little dots. You're going to show clotting issues by little micro bleeds in the skin. And you'll see a hematoma is where blood gathers into like a big pool. Bruises, a hematoma that's big enough, you know. And these can happen, it's a real issue when it happens inside your cranium, because your skull is solid, it's not going to give. And so if you have pressure in there, even a small amount of blood is going to cause pressure, it's going to push on the brain, you know, causing a coma and death, things like that. So there's a subdural hematoma, underneath the dura in your brain, and in soft tissues and joints, you can have blood that forms this hematoma bruise. The colors, I love the colors. You see kind of the yellow, it turns colors. It's just kind of cool. It has to do with the blood breaking down and the different colors. It's pretty cool. And then you really want to, when you're talking to a patient, especially if they're going to undergo surgery or even tooth extraction, anything like that, you want to see, do they have any history of bleeding issues? You ask them that, you ask them it twice maybe. And you also ask about family history, because it's possible they haven't had any issues with bleeding, but you know, maybe they haven't had a situation where, like, as they're going into surgery. So if they find, oh yeah, I have a, you know, my grandfather had a coagulopathy, then you really want to look more closely just to make sure, because you don't want to find out about a bleeding problem after you cut something. All right, what are the kind of tests? Platelet count. When you run a CBC, complete a blood counts, you get red blood cell numbers, you'll get thrombocytes. So if you see numbers like in the 700,000s, or you see numbers like in the 5,000s, you know it's too high, too low, and you've got thrombocytopenia, thrombocytosis. Believe it or not, the way we used to test clotting, clotting behavior, clotting efficiency, is with cutting you and then seeing how long it took to the bleeding to stop. You can imagine that's not a very popular test, and we have now expensive machines. You just put the blood in. And so this platelet function analyzer, it's just, you put the blood in there, it goes through, there's a little tube. It's got collagen in there that's going to make the blood really, it's going to make the platelets really stick to it. And just see how long it takes for that little tube to clog up and the flow stops. So it gives you an idea that, of clotting time. It doesn't tell you if there's an issue, what the issue is, but it gives you that. It's better than cutting someone and like timing their bleeding, right? They would cut the ear sometimes. All right, and these tests are big. These are big in hospitals, you'll see. And as I say, clotting is an issue with critically ill people and non-critically ill people. But you'll see a PTT, partial thromboplastin time. And this is a test that's done, better than bleeding you, where they take some blood and they test the time to clotting using a machine instead of an old-fashioned way. They add the things that need to be added. So they put in citrate when they collect the blood so it doesn't clot. I'm not going to allow calcium in there. And then when they bring it to the machine, it adds the calcium and it counter affects that preservative. And then they see how long does it take to clot. They can time that. And then PT, prothrombin time. What they do here is very similar. This is going to test how well you clot. And each lab and each machine is calibrated differently. So this time, you can't really compare among different labs. So you're going to hear, I hear this about INR, is the way that they normalize it. So each lab, they decide that a normal clotting person is a 1. And then you can see, are you, hyper or hypocoagulating, too much or too little. So that's what they'll do. And this is used all the time because people on warfarin, Coumadin, blood thinners, they need to go in and get it checked all the time. So what's their INR? You see, like, where are they at? So real commonly used by pharmacists and medical people. And then you can go in and measure the amount of fibrinogen. That'll tell you something, right? It's produced by the liver, it circulates in the blood. And if you have too little of it, you're not going to clot because that's what turns into fibrin. You're not going to make those fibers. And look at this, you just, an additional thing here, just looking at clot's going to form, and then you can see the fibrogen, how much of the fibers are there, and then the clots are going to be broken down, and so you see this shape. And reminded me, Lindsay gave a talk looking at different shapes, and some look like a champagne flute, some look more like a wine glass, beer stein or whatever. So you have different shapes to these that often look like glasses, and people look at clotting, and it's progression. All right, and finally we'll get to some diseases, and I put it in quotes, it's a little different. Other chapters we talk about genetic diseases, functional diseases. Here is going to be diseases that cause you to bleed too much or clot too much, right? And these are all very important, but it's a little different organization than most chapters. So that is the teeter-totter. You go between hemorrhaging or bleeding and thrombosing and clotting, right? And you want to keep that from going one way or the other. Too much bleeding, too much clotting, either one's going to kill you. So lots of diseases can cause clotting issues, right? Anything that causes injury to vessels like atherosclerosis, endocarditis, right? Anything that's going to screw up your platelets, you got a problem with your bone marrow, you got autoimmune disease, right? Or anything with all those different chemicals in that chemical cascade. You got liver damage, you're not gonna be able to make these proteins. You're gonna be low on prothrombin and fibrinogen. So so any disease that, you can see various diseases, one of the symptoms is coagulopathies. All right, so vascular disorders, trauma, cutting, fish hook through your scalp, happened to me. These things are gonna cause damage to blood vessels, right? If it's a serious damage, you wanna use pressure points. And if they bled out a lot already, and you get them to the hospital, you want to replace it with saline, replace the fluids, or they're going to go into shock, right? Hypotensive shock, low blood pressure. So it's very important if you lose a lot of blood to replace that fluids. You can replace the fluids usually, and you can make your own red blood cells, but you need to get that blood pressure up. And most significantly is that internal bleeding. Someone's in a car accident, I feel fine, but they've actually damaged their spleen or other vessels, and can cause mortality. You're going to end up bleeding internally until you have a shock, and then by then you've got all this blood in body cavities. It's not good. So here's a big chart from your book, and you don't have to memorize all these things, but these are just some examples of things that can cause damage to your blood vessels, right? Trauma, obviously, knife, cheese grater, asphalt, ice pick, anything that's going to cause damage to blood vessels, trauma-wise, right? And then infections can damage the vessel wall. Toxins given off by meningitis bacteria. Remember the endocarditis, infection of your heart valves, right? And that can make clusters of bacteria that can go off. Little vegetation can come off and travel somewhere else and lodge in a blood vessel and grow. Yeah. We'll talk about some of these in a moment here. But you can see when you have an aneurysm, it's going to cause blood clotting in there. If you don't make your collagen correctly, boy, it's hard to make a good blood vessel without some strong collagen around it. Immunologic, this is what we'll talk about next. This is the next slide. But you can have things that attack the endothelial of your blood vessels. Not good. Metabolic, sure, vitamin C is necessary to make collagen, to make strong blood vessels. Without it, you have weak blood vessels. Atherosclerosis is going to weaken the blood vessel. Amyloidosis, amyloid, yeah, is a protein that causes many problems, but it sticks to blood vessels and it'll weaken them. And any neoplasm, of course, any cancer, the blood vessel will weaken it, potential problem. All right, so here's one of these diseases that was in that chart that damages blood vessels. And I do not speak German. Don't make me say it. But this type of obvious problem causes these purpura, these purple spots that is bleeding in the skin. And what it is that kids will get a strep infection, and the antibodies against the strep bacteria, they will cross-react and recognize vessel walls. And so how bad is that? It's autoimmune, you're destroying your own vessel walls. And so you'll see bleeding into joints, bleeding into the GI tract, and this is potentially deadly, right? Cause renal failure, the delicate vessels. Because the immunoglobulins, the little antibodies, they get filtered out by the kidneys. If they're stuck in these big globs, they'll glom up those delicate glomerular capillaries. We know this, thrombocytopenia. Not enough thrombus sites, not enough clot, not enough freaking platelets. So thrombocytopenia, not enough platelets. Yeah, you don't have platelets, you're gonna have bleeds, right? So hemorrhages, blood in your urine again, blood into your gut, and you're gonna have blood in your stools. Yeah. And if you have thrombocytopenia, temporarily they can give you a transfusion of platelets, but you need to fix the problem. Here's one, ITP. This is one of those major kind of platelet disorders that you'll come across, and that is where your body's autoimmune attacks the platelets. And you can see idiopathic, meaning we don't know the cause. And so once these platelets have antibodies on them, macrophages will eat them up, and you end up, even though you may be making a lot of thrombocytes, even your body steps it up, you're destroying them. The antibodies are tagging them, macrophages are destroying them in your spleen, your liver, your bone marrow. Yeah. Well, it could be, say, autoimmune, or also you can see some other disorders like HIV and lupus can cause this. All right, a couple other diseases here, TTP and HUS. It's mainly in kids, mostly in adults. Thrombotic, thrombocytopenia, purpura. Clots, not enough platelets, makes these purple dots. It comes down to. And that's where the platelets are just used up faster than you can make them. And when that happens, well, the clotting in all various places can cause little tiny hemorrhages. It's going to cause little infarcts in your tissues. And here looking at, here's a TTP. You see kidney problems, all these little tiny clots, not enough low platelets, definitely, yeah, anemia issues. Yeah. Hypersplenism, so in a megaspleenia, you actually got a huge spleen, and that's going to suck up all the platelets. They're going to stop there. And the reason why I get a big spleen is often because of liver failure, because the splenic vein drains into the hepatic portal system into the liver. And so you'll get a backup in the liver will get enlarged. It will destroy and sequester platelets faster than you can make them. And it's like a sink for your platelets. Here, yeah, so platelet functioning, you remember this word? It's a good review from chapter 1. It's caused by our treatment. Medical professionals are causing this issue. Could be genetic, could be metabolic issues that are causing platelet disorders. Uremia, yeah, you have toxins building up in the blood because your kidneys aren't getting rid of it. We think that will damage platelets. And aspirin is interesting. Aspirin, salicylic acid, is helps with pain, with prostaglandins and pain, right? But it also involves a clotting. You all know, Grandpa had a heart attack. They said take a baby aspirin every day. It thins the blood, and it does. Too much aspirin causes bleeding, actually, but small doses will inhibit the clotting mechanism. All right, Some disorders include genetic diseases like hemophilia, and it's pretty rare. You can see 1 in 5,000 males is type A. Type B is like a fraction of that, very, very small. But people with these hemophilia, they have problems with these clotting factors somewhere, and they don't clot, and so it's very dangerous in that they can bleed from simple cuts, and they keep bleeding, and they get bruised easily. Yeah. And since it's genetic, it's also found sex-linked. It's found in the X chromosome. So it's rare. A woman would have to have 2 bad copies of it. Male only has 1 X, and so it's much more common in men. And yeah, and so hemophilia A, we know exactly that the mutation affects this factor 5, 6, 8. And we know B affects factor 9. So hemophilia B, called Christmas disease. I wonder, does it happen around Christmas time related to presents? I don't know. But no, it's the first patient was Stephen Christmas, and so it's nothing to do with the holiday at all. It's a little confusing if you ask me. But yeah, you can see nosebleeds, feces are tar-like because there's blood in there. It can have blood in the urine. Yeah, and easily bruising, easily bleeding. So there are like these inherited issues, but acquired coagulation disorders are more common. And it can be caused by issues with usually you don't have enough vitamin K. It could be diets. It could be you could have insulted it with toxins. Like I say, diseases can cause coagulation problems. That's the more common than having an inherited genetic coagulation problem. And if you don't have enough of any of those, you need all those ingredients for coagulation to happen, right? If you don't have enough of factor 7, 9, 3, all these things, anything, you're going to be an issue. And it's your liver that makes all these proteins, clotting proteins. And so if you have liver disease, yeah, you're not going to be able to make those proteins in many cases. And you'll see coagulopathies as an effect. So like I say, liver disease, either acute or chronic, is going to have an issue with producing these coagulation factors, which are necessary, right? Now, vitamin K is an interesting vitamin. It's fat soluble, and normally we get enough of it in your diet, because one reason is because bacteria in your gut make vitamin K too. So you can get it from leafy vegetables, or your bacteria make it. Now, there's an issue with newborns, because they're born, their gut doesn't have any bacteria in it. They acquire it from breastfeeding and from the bacteria in the skin and the environment. So early on, babies are given a shot of vitamin K, I mean almost always, just to help them so they don't have clotting issues. Another thing is when you give someone antibiotics for a disease, it actually influences the gut flora, the bacteria, and they can often have a vitamin K deficiency when you've taken antibiotics. So interesting how that's related. Your gut bacteria give you a lot of this vitamin K. And you need vitamin K for clotting. When I hear consumption coagulopathy, that means you are using up the chemicals and the platelets too much. And so that you've used it up and you need it somewhere else, you don't have it, right? And so interesting, hemophiliacs, they spend their life getting a lot of blood transfusions. And with these transfusions, they can build up antibodies. And then all of a sudden they start attacking the platelets they've been given. All right, the 2 big anticoagulants in the world, in the medical world, they are going to prevent clotting. Famously is warfarin, Coumadin, there's names for drugs. And what this does, it works by limiting vitamin K. And you use warfarin, well, if you've had a heart valve put in, artificial, you need to keep blood thinners so you don't make clots there. Several reasons why you want blood thinners: if you've had strokes, things like that. They want to keep your blood not clotting so much. Or if you have atherosclerosis, it tends to clot a lot. So maybe you put on warfarin, and it's a pill you take constantly. And so this is something, it actually takes weeks before it begins working, and then it's a slow-moving drug. And then you have to be really careful, because every patient is different in the amount of warfarin they need. And so these people come to the hospital doctors a lot just to get their levels tested, their clotting levels tested. Heparin, that is where you get a shot of that. They give it in your IV bag. So heparin works as an anticoagulant. It's a half-life of like 90 minutes or something. It works just quickly, all right? And so you get this if you're brought to the hospital with a stroke and they want to really give you an anticoagulant fast. Warfarin's used for long-term maintenance of your clotting issues. So heparin, and they use heparin, they use that to coat those cards we use for blood typing in lab, or tubes where they collect blood. They're heparin lined. It prevents blood clotting. And both of these have antidotes to that too. If you have too much of it and you're bleeding too much. The warfarin, I believe it comes from salmon sperm. Fun fact, I have to check on that one, but I'm pretty sure that's where the antidote comes. All right. All right, so let's take a look here. You can see thrombosis caused by vascular abnormal blood flow, coagulation, right? What are they going to do about this if you have too much clotting? Fibrolytic agents will be clot busting, right? Definitely. And then they got to see what is causing it, definitely. Because if you're making too many clots, the danger is, in fact, a moving clot that's going to be an embolus. It's going to clog up your coronary artery, your cerebral artery, your pulmonary artery. So that's the big issue when you have a thrombosis. You make too many clots. The endothelial, damaging of the blood vessel. Definitely atherosclerosis is a big factor. It damages the blood vessel, weakens it. You might have an aneurysm, but also roughens it. And it's not going to be expressing all those chemicals, the anti-clotting chemicals anymore, is it? Because now it's going to be a plaque. It's not going to be nice, healthy cells. So it's going to encourage more thrombi. These are the people who will be on warfarin. Yeah. So this shows a picture here looking at other factors that are going to influence this. And one is, again, the nice laminar flow is nice and smooth, and the platelets don't bump into each other, bump into the walls. But turbulent flow, you think about a stream where it's the rapids and it's going across the rocks. There's always those pools next to it, right, where the blood pools up. So any kind of pooling stasis at all is going to be an issue for sure. Blood pressure, smoke, all these chemicals are going to, or bacterial chemicals, the toxins are going to damage the blood vessels. Yeah, too much cholesterol. Here I show too much glucose in the blood is going to damage the blood vessels. All these things. And abnormal blood flow. We talked about either stasis or turbulence. Both of those, you're doing that to the blood, you're going to have more clotting. Yep. You keep them hitting the walls or not traveling in the middle. You especially see it in the legs when you see incompetent valves and the blood, instead of coming up, it's going back and forth. It's kind of static there. Or you sit for a long time and the blood kind of pools behind your knees. Well, thrombocytosis is too many thrombocytes, too many platelets. And I mentioned this isn't as big an issue as thrombopenia, but if you have too many platelets, you're going to have too many thrombi, too many clots. And so we talk about, if you have way too many, then you have thrombocytosis. And you got to look at the cause, and it is an issue. But I'm saying it's less of an issue than thrombopenia when you have lack of platelets. A lot of it, why do you have too many, is idiopathic. I mean, we don't know. You got too many platelets, we're not sure why. You could have cancers or hyperplasia where your bone marrow is just, you have so many megakaryocytes that they're making too many platelets, right? Splenectomy, you remove the spleen, and then all of a sudden you have too many platelets. Or other diseases, inflammatory diseases where platelets are increasing as well. So definitely you're going to see transient, meaning that this is normal. I mean, it's not good, but it's normal after an operation or after trauma or after childbirth. You often have a peak where you're, oh my God, the thrombocytes, they're really high, and that's normal, and they should come back down. And in patients that are in bed rest for too long, you got to watch out for that DVT. deep vein thrombosis. And you can see it kills so many people every year via pulmonary embolism. DVT by itself doesn't kill you, it's just a clot, but it moves, and then it can cause a heart attack, stroke, or pulmonary embolism. So when you're on the plane, you know, now they have helpful cards and instructions. A plane, I can't imagine flying anymore, but we'll be back in airplanes again. But you want to stand up, move around. And if you're in bed rest, you want to get up as soon as you can. They don't want the patient laying there too long. All right. And lastly, is DIC again. This is a real issue when all of a sudden you're throwing all kinds of little clots and then you're bleeding elsewhere. It'd be a nightmare, right? To try to put your finger in the holes over here and then, you know, to get rid of the blocks over here. So they will try to treat this, but it is an issue. All right, so I'll get us out of here. So we've discussed a lot of things here, looking at issues with bleeding and clotting. And you can see it is a seesaw. Too much bleeding, you bleed out. Not enough bleeding, too much clotting, you clot too much. You're going to block off vessels and they're going to go and cause issues. So very common to have coagulopathies, bleeding issues in patients with other chronic diseases for sure. So important subject. All right. Hope you're all doing well.